Hello, my name is Dr. Derek McHaffie, and I'm a radiation oncologist here at the Levine Cancer Institute. I've been practicing in Charlotte as a part of Southeast Radiation Oncology since 2011 after completing my residency at the University of Wisconsin. I have a practice focus in prostate cancer and look forward to meeting you at your upcoming visit. I found there's a lot of information to cover and discuss during a typical consult, with many questions naturally arising. I wanted to share this video with you so you can begin to understand more about your diagnosis, treatment options, and some details on radiation therapy. Please watch this video in its entirety prior to the consult. When we are together, I'll be able to provide you with some specific recommendations based upon the details of your case. Please be aware that many men will have multiple very good treatment options available, including both surgery and radiation. Understanding some of these basics before the visit will hopefully allow us to get the most out of our time together and make sure all of your questions are answered. It will also provide you a resource you can look back on if questions come up later. Before talking about treatment options, I wanted to give you a little background information. The prostate is a small organ about the size of a walnut. It lives just under the bladder, surrounds the urethra, and in front of the rectum. Prostate cancer is the most common site of cancer in men. In the United States, there were around 300,000 cases diagnosed last year. The good news is that most patients will undergo successful treatment. Because the chances of controlling the cancer are often quite high, decisions about the best possible management are often nuanced and center on when do we treat and how aggressive should we be. In order for treatment to be truly successful, we need to make sure you have the best possible chances of both controlling the cancer and preserving your quality of life. It is important, however, to understand that not all prostate cancers are created equally. Some are extremely slow growing, and others require immediate attention. To help us understand more about your prognosis, we complete what we call staging. For most types of cancers, you may have heard this referred to as stage 1 through stage 4. For prostate cancer, though, we approach it a little bit differently. We have created what we call risk groups. In order to determine your risk group, we take into account the extent of the cancer noted on prostate exam and any imaging you may have had. This is what we call T-stage, and also the Gleason score, or how aggressive does it look under the microscope when the pathologist evaluates your biopsy specimen. The third factor that we consider is the PSA level. Taken together, this allows us to stratify patients into either low risk, favorable intermediate risk, unfavorable intermediate risk, high risk, and very high risk. When I talk about risk, what I mean is the risk your cancer can return or spread after treatment. Our word for this is metastasis. Your risk group determines which treatment options are most appropriate. I would encourage you to spend a couple of minutes reviewing this table. It should provide you with a little sense for how a risk group can alter some recommendations and when more scans may be helpful. For men with cancer confined to the prostate or limited to the areas just beside the prostate, the goal for treatment is to eradicate it completely, prevent it from spreading or metastasizing. For some men, typically those in the low-risk group, active surveillance is often preferred. For low-risk cancer, the risk of spread within a 10-year period is only around 1 to 2%. There's a good amount of evidence that men with small amounts of slow-growing prostate cancer can be safely monitored for signs of growth before needing to pursue definitive treatment. Importantly, doing so does not compromise the prognosis. If you fall into this group, we will discuss this more in depth during your visit. If you have intermediate risk prostate cancer or higher, upfront treatment will be preferred in most cases. Most men will have options for both surgical removal of the prostate, known as prostatectomy, or radiation. National guidelines, based upon best available evidence, support both as preferred options. The reason is the long-term prognosis is the same between both of these strategies. The largest randomized trial ever conducted that compared surgery and radiation head-to-head is known as the PROTECT trial. It included over 1,600 men with organ-confined prostate cancer and showed that 15 years after treatment, the odds of being alive and cancer-free was the same for both treatments. There are often good reasons to prefer one treatment over the other based upon many factors. Other times it may simply come down to personal preference. During your visit, we will definitely talk through some of the advantages and disadvantages for both treatments. When I talk about radiation, what I mean is x-rays. These are high-energy x-rays that kill cancer cells. So the prostate remains in place, but you can focus or target the radiation on the gland. It comes in two forms, external beam or internal radiation. Our word for internal radiation is brachytherapy. Let's first cover external beam radiation. This is where the radiation is given from the outside in using a machine called a linear accelerator. The most common form of external beam radiation is what we call IMRT, which stands for Intensity Modulated Radiation Therapy. This is the term that describes how we shape and sculpt the radiation dose to make it as conformal as possible just on the prostate. IMRT is a process and not an event. Radiation is most safe and effective when you give it in a series of smaller treatments. In this case, the treatments are daily, Monday through Friday, for a period of weeks. There are different schedules depending upon your situation. Some treatment courses can be completed in as short as 4 weeks. Others may require 8.5 weeks of treatment. Each treatment is a short visit lasting only 10 to 20 minutes, and it's most like having an x-ray appointment. You lie on a table, still and flat. The machine moves around you. You don't see it, you don't feel it, you don't hear it. However you feel when you come in is how you will feel when you leave. No one will know you're taking treatment unless you tell them. You won't look sick or feel sick. There are no restrictions while you take radiation. You're free to continue working or participating in your usual activities. You just have to carve out the time to receive the treatment each day. The process begins with radiation treatment planning, what we call CT simulation. Radiation is not one size fits all. It's designed custom and specific for you. Everyone's anatomy is unique, and the prostate is a different size and shape. Radiation is most precise and accurate when the treatment is reproducible, so we make some custom molds for your legs so that we can position you the same way each day. Treatment typically begins 1 to 2 weeks after this visit and will continue daily. Any side effects you may experience from treatment are gradual and limited to the area where we are treating. Side effects could impact urinary, bowel, or sexual function. Changes in bathroom habits are common during treatment and can result from inflammation and swelling of the prostate, urethra, bladder, or rectum. The most common side effects during a course of treatment include increased urinary frequency or urgency to pee, weak stream when you pee, or trouble emptying your bladder, getting up more at night to pee, or sometimes burning or stinging when you pee. Some people have increased frequency of bowel movements or loose stool. About half of men will characterize their side effects as mild, which I define as changes that you notice but don't require medicine to help. The other half of men will have moderate side effects, which means they may benefit from medicines until things improve. Almost always, the side effects of radiation are temporary, meaning you will improve within 2 to 6 weeks after treatment. Maybe 1 in 4 people might require 2 to 3 months to get back to normal. Only rarely are they chronic. The risk of chronic side effects from IMRT is about 5 to 7% and could include chronic inflammation of the bladder or the rectum. The risk for very serious side effects is very low. Sometimes, radiation itself can actually cause a new cancer. What I mean by that is, if you're cured from prostate cancer, some men may develop a new cancer such as bladder cancer or rectal cancer 5, 10, 15 years into the future. The risk for this is small, but not zero. The best estimates suggest this is about 1 in 400 within about a decade of treatment. As I mentioned already, there are some different schedules for treatment and durations of treatment. In order to get done faster, you can deliver a little more radiation each day, meaning a shorter schedule is not less effective than a longer schedule. The best way to understand it is thinking about the difference between 4 quarters and 10 dimes. Either way, you get $1 worth. You may have come across the term SBRT, which refers to what we call stereotactic radiation. This refers to a way to deliver almost a week's worth of radiation in a single treatment, which allows you to complete prostate treatment in only 5 sessions, typically spread out over about 2 weeks. This provides a significant convenience for people who are interested in external beam radiation. Not everyone is a candidate, however, and the side effect profile is slightly different, but best available evidence indicates that the treatment is just as effective when offered to the right patients. The other option I would like you to be aware of is internal radiation, what we call brachytherapy. Instead of using a linear accelerator to deliver the radiation from the outside in, you use a small radiation source to deliver the radiation from the inside out. Brachytherapy is an event more than a process. It's a minor procedure that is done under anesthesia. There are two types of brachytherapy: LDR, which stands for low dose rate, and HDR, which stands for high dose rate. The difference between the two is what type of radiation source do I use? One that gives radiation very slow over a period of months, or one that gives the radiation very quickly over a period of minutes? Let's first go over LDR brachytherapy. This is more commonly known as a prostate seed implant. We call them seeds, but they're really capsules made of titanium. They look like a small pencil lead. They're hollow on the inside and contain a radiation material. Most commonly, it is iodine-125, which has a half-life of 60 days. So the seed is permanent. Once we put it in, it stays forever, but the radiation is temporary. It gives the radiation slowly over a period of months and eventually dwindles completely away. So the idea is, if we place the radiation directly on the inside, that is the best way to keep the radiation contained within the prostate to help keep it away from the bladder and the rectum. Also, you take it home with you, so you don't have to come back and forth for daily treatments. However, you are radioactive when you go home, so that comes with some minor restrictions. Mainly no holding babies and no children on the lap for about 3 months after treatment. Also, you would need to stay at least 6 feet away from anyone who is pregnant. Let's spend a few minutes reviewing the procedure itself actually and how it is done. Once you go to sleep, we place your legs up and use an ultrasound in the rectum to visualize the prostate, similar to how your biopsy was done. I place needles very precisely into the prostate using ultrasound guidance. When your biopsy was done, the needles went through the rectum. These needles actually go through the skin in the area just in front of the rectum. Once the needles are in, I strategically place each seed spaced out through the prostate to cover the entire gland with a dose of radiation and minimize radiation to the urethra, which is right in the center of the prostate. The procedure takes about an hour and a half, but you would be here for about half a day after anesthesia recovery. We do place a catheter in your bladder that would stay in place for 24 hours to reduce the chance you would have any difficulty emptying your bladder. For HDR brachytherapy, the procedure is very similar from the patient's perspective. It requires anesthesia, rectal ultrasound, and strategic needles inside the prostate. The key difference is that once the needles are placed, instead of depositing a radioactive seed, I connect the needles via catheter to a machine called a remote afterloader. This machine contains a single, very fast-acting radiation source, in this case iridium-192, which we can send inside the prostate for just a few minutes and then remove it. So nothing is left inside you permanently, and you would not be radioactive when you go home. Because the radiation is given more quickly, we cannot give as much radiation as we need to in a single treatment. So for HDR brachytherapy, 2 treatments are required, which are typically spaced about 1 to 2 weeks apart. If you are a candidate and interested, we can discuss further specifics of the procedure and aftercare instructions when we are together. We can also compare and contrast LDR and HDR a little bit further. It is worth mentioning that some patients with higher risk prostate cancer may benefit from what we call combined modality treatment, meaning half of the radiation is given external and half is given internal. When comparing brachytherapy with external beam, the list of potential side effects is essentially the same, but the way patients experience it can be a little bit different. It is important to point out that the acute side effects of brachytherapy, meaning the degree of urinary tract aggravation that you would experience immediately after treatment, are more prominent than with external beam radiation. Instead of being non-invasive, you are poking the prostate with some needles, which can contribute to more swelling. However, because the radiation is better contained within the prostate, the risks for chronic inflammation of the bladder and rectum are a little bit lower with brachytherapy. This risk is typically in the range of 1 to 3%. Some patients can be considered for proton therapy, which is a form of radiation that has existed for a number of decades but received a lot of attention recently as more centers are built. We are fortunate to have this option available at Levine Cancer Institute. Protons have both charge and mass, so they interact with tissue a little bit differently and provide some benefits in lowering side effects for certain patient populations. What I would like you to be aware of is that the best available evidence indicates that proton therapy does not improve quality of life when compared with more traditional, modern forms of radiation therapy in the routine treatment of prostate cancer. It may still be beneficial in certain circumstances, but most men will not benefit from this form of treatment. If this is something you're curious about, I'll be glad to discuss this with you in more depth during your visit. I would also like you to be aware that some men who receive radiation will also benefit from the addition of hormone therapy. Hormone therapy refers to a medicine, either a pill or an injection, given to lower your testosterone level. Testosterone can stimulate prostate cancer to grow, and it is sometimes necessary to lower this level to get the best possible result. Men who benefit from the addition of hormone therapy are those with high-risk prostate cancers and select patients with intermediate-risk prostate cancers. When given to the right patients, the combination of hormone therapy and radiation therapy can significantly increase your chances of remaining cancer-free after treatment by reducing the chances of cancer spread. If recommended, hormone therapy is typically given for at least 6 months and up to 2 years in some cases. It would be started before radiation therapy begins and continue after radiation is complete. You should be aware that it can be accompanied by some unwanted side effects, which are similar to the symptoms of menopause experienced by women. Common side effects include hot flashes, mood swings, weight gain, decreased libido, and decline in muscle mass. These side effects are temporary and reversible once hormone therapy is completed. When planning radiation, I put considerable effort into making sure the risk of side effects is as low as possible. As I mentioned previously, there is some risk of inflammation to the rectum from radiation that can lead to changes in bowel habits. It is possible to place what is known as a rectal spacer between the prostate and rectum during a course of radiation to reduce the chances of developing bowel side effects. This requires an elective procedure to inject a hydrogel in the small space between the prostate and rectum. This creates a separation between the prostate and rectum that moves the rectum away from the zone of high-dose radiation, which has been shown to reduce the chances of unwanted bowel symptoms. This hydrogel is a material commonly used in medical and other cosmetic procedures as filler. It is broken down and dissolves on its own over a period of months, what we call bioabsorbable, but it remains in place during the treatment to serve this purpose. This is not advised or appropriate for all patients, but I wanted you to be aware that it may be an option to consider. Benign swelling or enlargement of the prostate is common in men over the age of 60. This is known as BPH. Most men above the age of 60 have some degree of BPH. This can create trouble urinating that is entirely unrelated to the cancer itself and may have been happening for years or even decades prior to your diagnosis. Men who have good urinary function before treatment are the ones with the fewest side effects during and after radiation. Commonly, I will recommend some simple testing to make sure you empty your bladder well before we decide on treatment. For men who have difficulty with this problem, addressing it in some way, either medically or surgically, before treatment can set you up for the best possible outcome and lowest possible risk of side effects. Surgical treatments for BPH may include a procedure known as TURP, HOLEP, or prostatic artery embolization, or other procedure performed by your urologist. But it may be worth your time to think about these procedures before we meet, particularly if you feel you're having difficulty emptying. If you choose surgery, it is important to know that radiation therapy may be necessary after. Maybe 10 to 20% of patients with early prostate cancer may have their PSA rise at some point in the future following surgery, at which time we begin to entertain what's known as salvage radiation. For higher risk patients, the chance of PSA rising may be 40 to 60% or even higher, depending on how advanced the cancer is. Typically, radiation after surgery lasts about 7 weeks. Sometimes we will add hormone therapy as well. My previous comments about radiation logistics and side effects apply to post-surgery radiation as well. It is often said that if you have surgery first, you can still have radiation, but if you have radiation first, you can't have surgery. This is because scar tissue around the prostate after radiation makes it difficult to heal from surgery. However, it is important to know that the chance of having cancer regrow in the area the radiation is delivered is very low, approximately 2 to 3% at 10 years for most patients. After radiation, any cancer that is detected is usually somewhere else outside the prostate, either in a pelvic lymph node or in the bones. Unfortunately, this can happen at similar rates after surgery. This is why the best available evidence suggests that the chance of developing metastatic prostate cancer is about the same whether you start with surgery or start with radiation. If you were to end up in the small number of patients that do develop a recurrence in the prostate after radiation, then there are other options such as hormone therapy, cryotherapy, HIFU, or rarely re-irradiation. Often I'm asked, what can I do to help? While there are some things in this life that are beyond our control, we do think that maintaining a healthy lifestyle helps in many different ways. We do recommend continued exercise throughout treatment. Both cardio and strength training are important. For those taking hormone therapy, this is important to minimize weight gain, maintain muscle, and reduce any risk of osteoporosis. There is no specific radiation diet, but we would say many of the same things your cardiologist might say. A heart-healthy diet full of natural foods, low in saturated fats, simple sugars, or ultra-processed foods seem to be optimal. If you typically consume alcohol, there does not seem to be any serious interactions between small amounts of alcohol and radiation therapy. Here at Levine Cancer Institute, we are fortunate to have the Department of Supportive Oncology, and if you would like to discuss complementary medicine in depth, we are happy to place a referral. Well, this concludes the video. Thank you for watching. I hope you found it helpful. Now that you understand the basics, I hope that we can use our time to explore the nuances of your personal goals and wishes when we meet. I look forward to meeting you and wish you the best on your journey.